All right, good morning again. My talk is about managing complication and transfers in the outpatient lab. Conflict of interest for this talk, none. First of all, the safety in the OBL and the ASC has been well established over the last 10 to 15 years. We have two major papers. The first one by Dr. Armstrong. This is based on the Liberty 360 sub-analysis and shows that there is efficacy and safety between OBL and non-OBL sites are equivalent. Another recent paper in 2021 by Dr. Orshina, looking at low and moderate procedure risk patient with ASA score of 2 and 3 for the arterial intervention, and 0% peri-procedure mortality, 0.5% rate of minor complications, and 0.3% rate of 30-day mortality. So what is the difference mainly between ASC, OBL, and the hospital? Like Dr. Dippel mentioned, it's not the issue of what kind of complication you're gonna get. Your mindset has to change. There is no operating room in a sense you can transfer somebody who's bleeding. There is no anesthesia that's assessing you. It's just the physician, no blood bank, no code team, no other such specialties helping you, such as anesthesiologist, ER physician, or other physician coming and bail you out during a complications. And also you have to be aware sometimes you don't have all the equipment available. So you have to know what do you have in your lab and try to think ahead in case a complication happens. Also, you need to know your patient very well. The age of the patient, their SA risk, their BMI, their functional capacity, their other comorbidities. Look well into their allergies. If they have severe contrast allergy, probably it's best not to do them in the OBL in case they have an anaphylactic reaction and they will need intubation. So all those things need to be discussed with the patient and be thought ahead of time in order to handle complications well. Also adhere to a protocol. Don't cut corners, like it was said before. Always proceed with a timeout. Know all your access site. You'll never know which site is gonna bail you, either a radial or a tibial site for a bleeding complication, for embolization. Always use US guidance, ultrasound guidance for access. Like I said before, know your equipment. Know your crash cart, your bailout toolbox. Always have your medication doses posted in the cath lab. Suddenly, somebody goes into anaphylactic shock and you try to recall, or the nurses are scrambling to figure out the dosage and the dilution of the epinephrine or the Narcan. So let them be posted there, readily available. Know your skills, know your limits, know your procedure, and plan ahead. Also, you have to have a transfer agreement with the hospital. This it's from the SKY Expert Consensus in 2023, mostly applicable to coronaries. Also, you can apply it for peripheral intervention. A transfer protocol should outline communication between the ambulatory facility, emergency medical services, and the receiving facility. The ambulance should be large enough to accommodate large equipment with the optimal goal to arrive to the hospital within 30 minutes. Now, what are in my opinion, the most common complication that can occur in OBL or in ASC is the access site. So it's the beginning and the end. If you manage your access site from accessing it and closing it, this is probably you're avoiding 90 to 95% of the complications. The common femoral artery, we have the anatomical definition and the functional definition. It's the portion that lies over the pubic bone where it can be compressed, and it's very essential to access that site. The tips for common femoral artery access, I use combination of fluoroscopy and ultrasound. With the ultrasound, I'll mark in the fluoroscopy at the lower edge of the femoral head. The ultrasound, I'll find my bifurcation, scan upward till you find the common femoral artery. Look for size, for plaque, calcification. This will help you what kind of closure device you're gonna use later. Find a good spot. Always follow your needle. If you feel while you're scanning upward that the artery becomes smaller and deeper, most likely you're in the external iliac artery. And do not move the transducer once you're in good position. I do fluoroscopy again in the right oblique if I'm accessing the right common femoral artery, to make sure that my needle, before even putting the micropuncture sheath, to make sure that my needle is in a compressible area. Use a long stiff wire for large penis. If the J wire kinks, you can use the micropuncture sheath and exchange it for a stiff wire. If you have a lot of scar tissue from previous intervention, use an introducer that 1 French size bigger than the sheath that you want to use, and then put your appropriate sheath. If the puncture is too high and you're stuck with it, use a closure device, but always make sure that you have hemostasis by an angiogram, either by contralateral, or probably you can use a micropuncture kit, go lower and inject to make sure that you have hemostasis. For the antegrade stick, also ultrasound guidance. If you have unfavorable body habitus, consider proximal SFA, stiff wire, and think of another access in order to bail you out. One of the complications that can happen with the PER close that can be stuck, and there is a way to deal with it. You can dismantle the PER close, take it away, and you'll be left with this structure, and this is connected to the plate or the foot plate. You can then push it down and pull your PER close instead of pulling on the artery. With the angioseal, it can be stuck at times. This is one case that I had, and typically what I do with the angioseal, I keep the string with the hemostatic clip on it, make sure that I have a pulse. If I don't have a pulse and there is a lesion and you're in the ASC, you need to be bailed out. This is one case that I did. And you take a balloon by pulling on the string, an oversized balloon at low pressure, you inflate for 5-10 minutes, and you bail yourself out and make sure that there is no embolization instead of transferring the patient. And this is the patient Doppler. 2 months later, he has good flow through the common femoral artery and the SFA. Embolism, you have to think about them ahead, especially if you have in-stent stenosis, especially if the wire travel easy and you don't have inadequate ACT. Devices that we use in the cath lab is the Pounce device. It can be used in the common femoral artery, even in the small vessels. Another device is the penumbra bolt. This is a case that actually the Pounce device, those materials were too heavy or too much for the Pounce device. It wouldn't retract, so we used the penumbra bolt to suction it. Perforation, iliac perforation, again, you have to think ahead in CTO, calcified vessels, small vessels, female. Start with the appropriate sheet size if you think that you might be facing perforation and you want to use a cover stent, that this sheet is appropriate for the cover stent. Avoid long balloon in the external iliac artery, and might be a role for the shockwave balloon in the very calcified vessels. In the small vessels, this is a case where I had a small vessel perforation with a polymer jacketed wire. Typically use the same wire to go back to that vessel and embolize it. For contained rupture, a long balloon inflation will handle this. And for slow flow, short runs, short segments, prepare with medication, take a break between runs, and consider filter when applicable in single vessel runoff. Finally, for coronaries, the problem is that the covered stent is limited in the ASCs because you need an IRB approval. However, to avoid this, use IVUS, avoid heavily calcified vessel. Always preload with the dual antiplatelet therapy. Make sure you have adequate ACT. Thank you.